1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, usually when we talk about a medical diagnosis, there's this expectation of absolute precision. Like, it feels kind of like engineering, right?
Yeah, exactly. You want it to be straightforward.
Right. You break your arm, the x-ray shows that, jagged white line, and the doctor just points at it and says, there it is. It's visible, it's clean, and honestly, it's really comforting.
Oh, for sure. I mean, we definitely prefer things that can be, neatly categorized.
Mm-hmm.
If you can actually see the problem, you feel like you can fix it with a very specific targeted tool.
But then you step into the world of psychiatric care and psychopharmacology, and suddenly that x-ray machine is just completely useless.
Oh, completely. It's a totally different ballgame.
Right. We're looking at a therapeutic landscape that is just incredibly murky. I mean, the medications don't just set a broken bone. They are fundamentally altering the chemical landscape of the human brain. And today, for this deep dive, we're looking at a specific medication that perfectly illustrates this complexity.
And that would be Ziprasidone, right?
Exactly. Ziprasidone, commonly known by its brand name, Geodon. And our mission today is to extract that vital 20% of clinical information that is going to give you, the listener, 80% of the understanding you actually need.
Right, because we want to build clinical intuition for nursing school and clinical practice, not just, memorize a stack of flashcards.
Exactly.
Which, honestly, is the only way to practice safely. I mean, if you just memorize a list of side effects, you'll forget them the second you walk into a patient's room or sit for the NCLEX. But if you understand the molecular mechanism, like the invisible architecture of what this drug is doing, then the nursing actions and bedside interventions become completely logical.
So let's start right at the molecular level then. At its core, ziprasidone is classified as an atypical antipsychotic, specifically a serotonin-dopamine antagonist, or an SDA.
Right, an SDA.
Now, I want to try an analogy to visualize how it's actually, doing the heavy lifting in the brain. I like to picture ziprasidone as this highly skilled, incredibly strong bouncer at a really chaotic nightclub.
Okay, I like where this is going.
So you've got the mesolimbic tract in the brain. That is the area where the dopamine party has gotten completely out of control. It's way too rowdy. And that excess hyperactive dopamine is what drives the positive symptoms of schizophrenia.
Right, the things that are added to the patient's experience.
Exactly. The auditory hallucinations, the intense delusions, the paranoia. So ziprasidone steps in, stands in front of the D2 dopamine receptors, blocks those doors, and just stops the dopamine from causing chaos.
I love the bouncer analogy, and we can actually take it a step further.
Yeah.
Because a good bouncer doesn't just kick people out, right? They also manage the VIP section to make sure the right people are getting in.
Oh, okay. How does that fit in?
Well, that's where the serotonin component comes into play.
Mm-hmm.
Because in schizophrenia, you also have negative symptoms, things like severe apathy, a flat emotional affect, or an inability to feel pleasure. And these are actually thought to be linked to a deficit of dopamine in a completely different part of the brain.
Wait, really? A deficit?
Yeah, specifically in the mesocortical tract.
Wait. So there's too much dopamine in one area, but literally not enough in another.
Precisely. And this is exactly why older typical antipsychotics were so flawed. I mean, they just universally block dopamine everywhere.
Which would just make those negative depressive symptoms even worse, right?
Exactly. But ziprasidone is smarter. It blocks serotonin 5-HT2A receptors. And normally, serotonin inhibits dopamine release. So by blocking the inhibitor, ziprasidone essentially disinhibits dopamine in that specific cortical area.
Oh, wow. So it tweaks the chemical balance.
Right. It cools down the rowdy sections while bringing a little more, life to the quiet, apathetic sections. That's the expected therapeutic effect.
That makes perfect sense. But the bouncer isn't perfectly precise, right? Because I was reading about its receptor affinities, and it seems like there's definitely some collateral damage.
Oh, absolutely.
It's like the bouncer's doing a great job managing the doors, but he's so big he accidentally leans against the club's main light switch and cuts the power.
That is a perfect way to look at it.
Yeah.
And that collateral damage is the key to anticipating your patient's side effects. Because Ziprasidone has a high affinity for alpha-1 adrenergic receptors, and it acts as an antagonist there. And it also acts as a moderate antagonist at H1 histamine receptors.
Okay, so if it's blocking histamine, that immediately explains the severe drowsiness. I mean, you give someone a strong antihistamine, they want to sleep.
Exactly.
And blocking alpha-1 receptors, those are responsible for vasoconstriction, right? So if we block them, the blood vessels dilate and blood pressure just drops.
You're anticipating the clinical picture perfectly. But before we get to managing those side effects, we have to look at the expected action. Like, how do you know it's working?
Right, the clinical signs.
Yeah. When this medication is working, whether for schizophrenia or, as mood stabilization in bipolar I disorder, you will see a tangible decrease in agitation. The patient's thought processes become much more organized.
And their reality testing improves, right?
Exactly. Meaning they are more anchored in the present moment rather than, responding to internal stimuli.
Okay, so if this drug is that effective at managing these neurotransmitters, how are we actually getting it into the patient's system? Because the pharmacokinetics here seem wildly different depending on how you administer it.
Oh, they are completely different beasts. Let's look at the intramuscular injection, the IM route first. This is used specifically for acute agitation and schizophrenia when you need very rapid control.
Right.
The IM route is 100% bioavailable. It hits its peak concentration in just 60 minutes, sometimes even faster, with a half-life of about 2 to 5 hours.
And the reason it's 100% bioavailable is because it completely bypasses first-pass metabolism in the liver, right?
Absolutely. When you swallow a pill, it goes into the stomach, gets absorbed into the portal vein, and goes straight to the liver. And the liver filters and metabolizes a huge chunk of the drug before it ever even reaches systemic circulation.
But the IM injection skips all of that.
Right. It skips that entire hepatic detour. It goes straight from the muscle tissue into the bloodstream and right up to the brain.
Which brings me to the oral route, because there is a massive trap here that genuinely shocked me when I was reviewing the clinical data.
The food rule.
Yes. The text explicitly states that oral administration with food increases absorption up to 2-fold. So wait, if a patient takes their morning capsule with just a sip of water on an empty stomach, are they essentially only getting half of the intended dose?
Yes. Orally administered ziprasidone only has a bioavailability of about 60% to begin with, and that is only when taken with food.
Oh.
Yeah, the drug is highly lipophilic, meaning it really needs the presence of fats and the physiological process of digestion to be properly absorbed through the GI tract. Without a substantial meal, that absorption just plummets.
I'm just thinking about, a new nurse on a busy med-surg or psych floor. You're doing your morning med pass at 7 a.m. and the breakfast trays don't arrive until 8 a.m. You hand the patient their ziprasidone, they swallow it with water, and you just inadvertently cut their therapeutic dose in half.
It happens all the time, and it leads to massive clinical confusion.
Yeah.
Because the provider might see the patient is still experiencing psychosis and increase the dose, thinking, oh, the medication isn't working.
Oh, I see where this is going.
Right. Then, a few days later, the patient happens to take that new higher dose with a heavy dinner, and suddenly they're completely over-medicated, sedated, and dangerously hypotensive.
So patient education here is completely non-negotiable. The food rule is absolute. They need to swallow the capsules whole, take them at the same time daily to maintain a steady state, and always take them with a meal or a substantial snack. Zero food means zero therapeutic absorption.
And that kind of practical application is exactly what separates basic memorization from, advanced clinical judgment.
Speaking of practical application, let's talk about the physical handling of this medication, because there is a detail on the National Institute for Occupational Safety and Health, the IOSH hazardous drugs list, that really stood out.
The Group 3 classification.
Yeah, ziprasidone is a Group 3 hazardous drug. Why on earth do I need to gear up with double chemotherapy gloves to prepare an antipsychotic? We usually associate those protocols with, oncology.
It is a striking requirement, for sure. IOH classifies it this way due to the potential occupational hazards of chronic exposure over a long career.
Okay.
While a single exposure isn't going to cause immediate harm to you, constantly handling a medication that fundamentally alters neurochemistry, endocrine function, and receptor pathways. Well, that carries long-term reproductive and systemic risks for the clinician.
That makes sense.
So if you are preparing the injectable form, you are required to use double chemotherapy gloves, a protective gown, and you have to prepare it in a biological safety cabinet.
Even for the oral capsules, the guidelines suggest using gloves and manipulating a tablet like trying to cut or crush it, which ruins the absorption profile anyway, dramatically increases the risk of aerosolizing the powder, which could require respiratory protection.
Exactly. It's a vital safety measure. Your health matters just as much as the patient's.
Okay, so let's drill down into actually administering that IM injection, because the rules here are rigid. It feels like there is zero margin for error.
You're right. These are independent nursing actions you have to execute perfectly. First, Ziprasidone is a loner. You never, ever mix IM Ziprasidone with any other medications in the same syringe.
Got it. No mixing.
Second, it requires specific reconstitution. You must use exactly 1.2 millimills of sterile water for injection SWI. And you shake it vigorously until it's completely dissolved into a colorless or pale pink solution.
So if a nurse, instinctively grabs a standard flush syringe of normal saline to reconstitute it, the drug is ruined.
Completely ruined. It will likely precipitate or crystallize. It absolutely must be sterile water.
Yeah, okay.
And once it's ready, the injection technique is critical. It has to be injected slowly and deeply into a large muscle mass, usually the upper outer quadrant of the gluteus maximus or the lateral part of the thigh. This is not a medication you casually pop into the deltoid muscle in the arm.
Right. And once that needle comes out, there's a strict safety precaution. The patient has to remain in a recumbent position, basically lying down for at least 30 minutes.
Which brings us right back to our bouncer leaning on the light switch.
Exactly. Because the IM route hits the bloodstream instantly, that alpha-1 receptor blockade hits hard and fast. The blood vessels dilate systemically.
So if they stand up,
If the patient stands up immediately after that injection, gravity pulls all that blood down, the vessels can't constrict to compensate, and you get severe orthostatic hypotension. They will bottom out their blood pressure, faint, and potentially suffer a catastrophic fall. Man, we're already seeing the physical toll this drug can take, which pushes us into the real danger zone, the severe side effects and adverse reactions. We mentioned the drowsiness from the histamine blockade, and we know weight gain and dizziness are common, but the severe life-threatening reactions are terrifying. Let's talk about neuroleptic malignant syndrome, or NMS. What is actually happening in the brain to cause this?
NMS is a rare but potentially fatal neurological emergency. We talked about how Ziprasidone blocks dopamine.
Right.
Well, if that blockade becomes too intense in certain parts of the brain, the whole system basically crashes. In the basal ganglia, the area that controls movement, severe dopamine depletion causes extreme lead pipe muscle rigidity.
Oh, wow.
And in the hypothalamus, which acts as the body's thermostat, dopamine blockade destroys temperature regulation, leading to dangerous hyperthermia. We're talking fever sometimes pushing over 104 degrees Fahrenheit.
That is horrifying.
Add in autonomic instability like wild swings in blood pressure and heart rate, and you have a true emergency requiring immediate cessation of the drug in intensive care.
And then there's tardive dyskinesia, which involves involuntary repetitive body movements like lip smacking, tongue protrusion, or grimacing. But wait, why does blocking dopamine cause extra movement?
It's a fascinating, albeit tragic, compensatory mechanism. When you constantly block dopamine receptors with a drug like Ziprasidone for months or years, the brain tries to adapt.
It fights back.
Yeah, it thinks I'm not getting enough dopamine signal, so it upregulates. It creates more dopamine receptors, and the existing ones become hypersensitive. Eventually, even a tiny amount of endogenous dopamine triggers an exaggerated involuntary motor response. And the worst part is, tardive dyskinesia can be irreversible even after you stop the medication.
The ripple effects of this drug are just astounding. I want to bring up another major clinical link regarding the endocrine system. The literature points specifically to the tuberoinfundibular tract.
Yes, this is a vital pathway to understand, especially for patient compliance. Under normal circumstances, dopamine in the tuberoinfundibular tract acts as a prolactin-inhibiting factor. It constantly tells the pituitary gland to, stop releasing prolactin.
Okay, so if Ziprasidone steps in and blocks that dopamine, the brakes are off.
The brakes are completely off. Prolactin levels spike. And for the patient, this translates into intensely distressing physical changes. We see gynecomastia, which is breast tissue enlargement in males. We see galactorrhea, which is inappropriate milk production regardless of gender.
Oh my goodness.
And in females, amenorrhea, the cessation of menstruation. When you understand the mechanism, you see exactly why a patient might suddenly refuse their medication. It's not just non-compliance. They are experiencing profound bodily changes.
So let's talk about combining this with other medications. If it's already dropping blood pressure and causing severe drowsiness, combining it with other CNS depressants like alcohol, benzodiazepines, or opioids sounds like a recipe for a massive, potentially fatal fall risk.
Oh, it's a huge additive effect that you have to monitor closely. Pharmacokinetically, ziprasidone is highly protein-bound over 99%. But it surprisingly doesn't aggressively displace other highly protein-bound drugs.
Okay, that's good at least.
But it relies heavily on the liver, specifically the CYP3A4 and CYP1A2 metabolic pathways. If a patient is taking another drug that inhibits those enzymes, like certain antifungals or antibiotics, the liver can't clear the ziprasidone and toxicity builds up rapidly.
I also notice a specific contraindication for the IM route regarding the kidneys.
Right, so the IM formulation contains a specific excipient called a cyclodextrin, which helps the drug dissolve in water. That cyclodextrin is cleared exclusively by renal filtration.
I see.
So while you don't generally need to adjust oral ziprasidone for kidney problems, giving the IM form to a patient with severe renal impairment can cause that excipient to accumulate to toxic levels.
Got it. Now we have to address the most serious warning of all, the black box warning. This applies across the board for atypical antipsychotics.
Yes, there is an increased risk of mortality in elderly patients who are treated for dementia-related psychosis.
Wow.
When these drugs are used in that population, the rate of death increases significantly, typically resulting from sudden cardiac events, heart failure, or infections, primarily pneumonia. The Beers criteria, which guides safe medication use in older adults, explicitly lists antipsychotics as potentially inappropriate, emphasizing they should be avoided for behavioral issues in dementia, delirium, or Parkinson's.
This presents a massive ethical and practical challenge in long-term care facilities. I mean, behavioral issues, agitation, and psychosis are incredibly common as dementia progresses. How do clinicians navigate that if this drug carries a black box warning for that exact population?
It requires adhering to strict federal OBRA guidelines, the Omnibus Budget Reconciliation Act. In a long-term care setting, you cannot just prescribe an antipsychotic because a patient is confused or, generally agitated. Therapy can only be initiated if the patient is a documented danger to themselves or others, or if they are experiencing clear, distressing symptoms of genuine psychosis or mania. Even then, the documentation must be exhaustive, and the facility is required to attempt gradual dose reductions, or GDRs, regularly to try and get the patient off the medication entirely. It is a last resort, not a first-line convenience.
Wow. We have covered a massive amount of high-stakes pharmacology here.
We really have. And in the heat of an exam or a chaotic clinical shift, you need a mental anchor to hold on to all of this.
So let's build that anchor. If a nursing student is walking into their NCLEX tomorrow, or a clinician is walking onto the floor, what is the absolute non-negotiable must-know for ziprasidone?
The bioavailability factors. Oral ziprasidone must be administered with food, a substantial meal. If you give it on an empty stomach, you are having the dose. For the IM route, the patient must remain recumbent for 30 minutes post-injection to prevent severe orthostatic hypotension from that rapid alpha-1 blockade.
Perfect. What's a classic test trap they'll try to catch you on regarding preparation?
Mixing the IM injection. Never, ever mix ziprasidone with another drug in the same syringe, and remember the diluent. You can only reconstitute it with 1.2 milliliter of sterile water for injection. Normal saline will ruin it.
And if we're looking for a nice to know, that protects the clinician?
Respect the IOS guidelines. It is a hazardous drug. Wear your double gloves and use the proper safety cabinets when preparing the injectable to protect yourself from chronic occupational exposure.
The ultimate clinical red flag here seems to be cardiac related. We talked about the black box warning for sudden death in the elderly, but ziprasidone also carries a severe, well-documented risk of QT prolongation on the ECG.
That is critical. It lengthens the time the heart's ventricles take to recharge, which can trigger a rapid, life-threatening arrhythmia called torsades de pointe. You must monitor that ECG and ensure they aren't on other medications that also prolong the QT interval.
Let's give you a one-sentence memory hook to lock all of this in. Ziprasidone zaps psychosis, but zero food means zero absorption. And watch the Z-axis on that ECG for QT prolongation.
I really like that. The Z's tie the most dangerous and practical elements together beautifully.
Thank you for breaking this down so clearly. We've gone from the microscopic affinity of a 5-HT2A receptor all the way to the bedside, putting on double chemo gloves to administer a life-saving, yet highly volatile medication.
It's a perfect example of why I find pharmacology so endlessly fascinating. But it also raises a massive question about where medicine goes from here.
What do you mean by that?
Well, think about everything we just discussed, the trial and error nature of it all. We give a patient Ziprasidone hoping to quiet a hallucination, but we essentially have to cross our fingers that they don't develop tardive dyskinesia, that their liver enzymes process it correctly, and that their QT interval doesn't dangerously stretch out.
It's risky.
We're using a blunt instrument, but we are standing on the edge of the pharmacogenomics revolution.
Oh, personalized medicine. Mapping the patient's genetics before we ever hand them a pill.
Exactly. Imagine a world where, instead of guessing if Ziprasidone will cause a severe adverse reaction, you swab a patient's cheek. You run their genetic profile, and you know instantly exactly how their specific CYP liver enzymes will metabolize the drug.
Oh, wow.
You know the exact density of their D2 receptors. If they are genetically predisposed to drug-induced QT prolongation, we could entirely eliminate the danger zone we just spent half this deep dive talking about. We wouldn't be managing collateral damage. We would be delivering a perfectly tailored chemical key for a specific patient's brain.
That is an incredible thought to end on. We started this deep dive talking about the visible, comforting precision of an X-ray. Right now, psychopharmacology doesn't have that precision. We are relying on your clinical judgment, your understanding of these unseen systems, and your vigilance at the bedside to keep the patient safe. But maybe, with pharmacogenomics, that precision is exactly where we're heading. Take these clinical pearls into your next shift. Remember the food rule, respect the handling protocols, and monitor that ECG. Thank you for joining us on this deep dive. Keep learning, keep questioning, and we'll catch you on the next one.